So Dr. V, if I have to choose just one thing, that if somebody is really having very bad bloating, which one would you do to heal the bloating?
One thing. That's a hard question, Doc.
Yes.
One good test would be would really to have them fast if they
Mhm.
haven't fasted at all, because
Mhm.
you want to see if the bloating is actually coming from something they're eating or if it's completely unrelated. Remember,
Yeah.
there are many causes to bloating. And in women, we always want to think about hormones, right? And the ovarian process there, right? So that's
Mhm.
to think about. But I think the first thing I would do is actually have them fast and
Mhm.
see whether the bloating gets better or
Mhm.
whether it stays the same.
So how long to fast in order to see the difference?
I would definitely have them fast for a minimum of 6 to 8 hours. I want that
Mhm.
migraine motor complex to cycle a couple times and see what's going on. So like, from when you go overnight, most people can't tell whether they're bloated or not. They're asleep, right? But when they wake up, I'll probably say, have your first meal around 1 or 2 o'clock, and let's
Mhm.
see how you do, and let's see how you respond. Yeah.
Mhm. When they have bloating, sometimes they come with some stomach cramps as well, some gastric pain as well. What if the patient is telling you that whenever they don't eat, they have this gastric pain? Should they still do this fast to check whether the bloating is coming from the food or not?
So if a patient tells me that when I don't eat, they're already telling me that when I fast, I have a
Mm.
problem, then I'm concerned, right? I don't think it's related to food. I feel like it could be related to something else going on inside the stomach, right? Does my patient have ulcers? Do they have H. pylori? What else could be causing symptoms? So at that point, I kind of want to do a deeper dive into some pathology in the stomach, in the gastric lining itself. Yes.
That's great. So
Yeah.
my next question to you is that you talk about leaky gut, right? Yeah,
Yes.
and how everyone knows that leaky gut is something true. It's not something that we fantasize. And how would your approach be in treating leaky gut, especially advisors to those gastroenterologists or even doctors out there that have never approached leaky gut before this?
I think the first place is really to embrace it as an entity that really exists. It is real. It is shown in the microbiologists talk about
Mhm.
it. The clinical researchers, the basic science researchers all talk about intestinal hyperpermeability. So we can call it whatever we want to call it, but it is
Mhm.
truly leaky gut. So embracing it first and not just like pushing the patient away and just saying, oh, that's nonsense, right? Because that already
Mhm.
causes distrust between the patient and the physician. So saying, yes, this entity really does exist. There are different reasons why. So we have to look, one person's leaky gut is different to another leaky gut. Remember, it is a syndrome of something going on, right? Intestinal hyperpermeability is a
Mhm.
syndrome of something. And so you still have to dig deeper to find out why the leaky gut. But there's a wonderful article that was actually published that I feel all gastroenterologists should read, just
Mhm.
published in March of 2025,
Yeah.
sort of like top key strategies in trying to heal leaky gut. It's there, it's laid out, the evidence is there. And Doc, there are a couple of things they talk about. They talk about the importance of fiber and diverse types of fiber. They talk about some elimination diets, but like low FODMAPs, but we all have our issues with elimination. I think it
Yeah.
really has to be personalized for the patient and
Yes.
customized.
Mhm.
They talk about the right type of probiotics, which is usually multi-strain, bifido and lacto. They talk about using glutamine.
Mhm.
There's lots of studies on glutamine and leaky gut. They also talk about immunoglobulins, like serum bovine immunoglobulins, to
Mm.
improve the immune system of the gut. And one thing we can't forget is motility, 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 right? We have to ensure that the motility of the gut is working so everything can flow. So if there's constipation, let's address it. And if there's diarrhea, let's also focus on that.
I
So there,
see.
there are definitely solutions.
And you mentioned just now about probiotics, right? So how would you choose between pre and probiotics? And if you have a choice, would you choose both or you either go with either one of it?
If I had a choice, I would choose nutrition first. I would
Oh,
choose food as a prebiotic, right? Because that food will, it's such a natural, I think when we give supplements, they always say this term, I don't know if you've heard it, you can't out supplement a bad diet, right? You can't give
Yes,
enough supplements
yes,
to fix the
exactly.
bad diet, right? So I
Yep.
think even before that, you always want to look at nutrition first, see what the patient is eating, and really, if you can, enrich the gut with prebiotics, which will feed the good
Mhm.
bacteria in the gut. So you're naturally giving them the right types of good bacteria, which is the probiotic. But it does depend on scenarios. It depends on the
Yep.
situation in terms of, is this someone who needs a prebiotic right now or probiotic? Prebiotics can cause a lot of bloating in some
Mm.
patients, very poorly tolerated. So it really depends where they are in the phase of the 5R protocol. But
Mhm.
at some point, you always want to feed, and you are going to feed with prebiotics, because that's that source that's really going to engraft into that into the lining, and graft that the bacteria, they are going to engraft into that mucosal level layer and stay and continue to really be the healthy
Mm.
feeders and really soiling properly. So it does depend, but a combination of both at the end of the day is best.
And do you have
Yeah.
any favorite prebiotics food that you would like to recommend to most of your clients?
A good fermented milk is great. For people who can tolerate it, a good fermented milk is great. And it doesn't have to be dairy. It can be plant-based as well.
Hmm.
We hear here in the United States, we hear a lot about kimchi. Everybody's eating kimchi,
Yes.
right?
Yeah.
And I
Same
know
goes.
that for breakfast, lunch, and dinner, I think in Asia, a lot of people are having kimchi on a regular basis. Onions and garlic, if you can tolerate it, are great sources of prebiotics, right? That you can add to your food at any time. So it doesn't have to be anything fancy or special. They could just be things that you're incorporating on a regular basis into your diet. Yeah.
That's great. So,
Yeah.
in the cases, let's say, if those who are having Crohn's disease, then do you think that, they've been suffering for years and years, I suppose, and most of the time they will be told to live with it, you know?
Yes. Yes.
What is your point when it comes to whether this Crohn's disease can be cured or not?
That's such a good question. I saw that question pop up. Can Crohn's disease be cured? I think gastroenterologists would kill me if I said it could be cured completely. But also, I have seen patients who have healed themselves naturally through diet and nutrition. Now, I will say this. I'm an integrative gastroenterologist. I practice the best of both worlds. If my patient has very severe Crohn's, because we can see it scaling from just mild inflammation with symptoms here and there, to our patients who have fistulas and strictures and obstruction and need surgery, those patients, the immune system is so crazy that we need stronger medications to calm things down. But I have also in my practice met with wonderful patients who came in early for initial early signs and symptoms. So they have like a mild to moderate, and we've been
Mhm.
able to work wonders with nutrition and natural supplements like high dose curcumin, right? Turmeric,
Mhm.
high dose
Yes.
omega. And in our practice, we use quite a bit of low dose naltrexone to regulate that immune response. And we have seen patients, two just popped to mind. I see them once a year. They just come and check in. And could I
Mhm.
say their Crohn's is cured? I think they're in such deep remission. They have no symptoms at all. And I always like to confirm with a colonoscopy, because I want to prove to myself, right, that not just
Yeah.
symptoms are better, because sometimes there's a disconnect. And I do a colonoscopy and I'm like, wow, like can't even tell you have Crohn's. So I
Mhm.
think we can definitely help these patients get into deep remission. And
Mhm.
even with our patients who suffer from Crohn's disease, who may have more severe disease, studies and
Mhm.
studies are showing us that the healthier the gut, the healthier we can maintain through diet, lifestyle, reduction of stress, the better their response to treatment as well, right? Even conventional treatments. So it makes a
Mhm.
difference. Yeah.
I see. That's great. So you really give hope to people who are really suffering from Crohn's, and there's chance where they can actually heal completely, not completely, but like what you say, in deep remissions, right?
Remission.
Yeah.
Yes.
The other thing is about now, I think this is a big topic and everyone
Okay.
loves coffee. So, but those people who love to take coffee and they'll be
Uh-huh.
wondering like, is a black coffee is better or milk coffee is better for the gut?
Have black, have some milk. I mean, again, this is one thing I'll say, Doc, about functional medicine, right, Shirley? It's all about personalization. So the one thing about coffee is that I think I read a study recently that says coffee saves lives or something like that, or reduces cardiovascular disease. There are so many benefits in terms of the antioxidants present in clean coffee sources that it's a wonderful natural detoxifier for the liver. I encourage it in my patients who have fatty liver disease and things like that, or autoimmune liver disease. I say 1 cup in the morning is fine. That's totally fine. Now, it's very often what we add to the cup that
Yeah.
sometimes is right? When you go order your coffee at these special, these boutique coffee places, there is a ton of sugar. There is a ton of milk that has a lot of emulsifiers and other things potentially if you're not using just a clean, like a whole milk or something like that. And even the fake sugars can be an issue for some people if you're doing sugar-free. So it depends. If you have lactose intolerance or casein sensitivity, you may not want to, right? You may not want to add all that added sugar. But hey, there are some people who have their coffee with milk. They don't have issues with it and they do just fine. So it's all about personalization. There's no hard rule on anything. Yeah.
But definitely black coffee would be a good choice to start
I
with.
think, yes, I think a good clean source of black
Yes.
coffee, great antioxidant, good to start with. Yes.
Out of the topic, do you like coffee, Dr. V?
I was a coffee addict
Oh,
for many
really?
years. Yes, I was a coffee addict and I had to quit. Because I couldn't sleep and I had really bad acid reflux. And I was taking medications. I was taking proton pump inhibitors, Nexium, Prilosec, whatever. And then I quit coffee and it all went away. So I had to give up. Yes, I had to give up coffee. So I didn't have acid reflux.
Just 1 cup of coffee a day.
I know some people, if you're an addict, you know yourself. It's not going to stop at
Yeah,
one.
it's not
Some
one
people,
cup,
it's like 2 or 3 and 4. So I said, no, I just have to stop.
Actually, I'll be going to the States probably in July, August, and my partner actually owns coffee farm and then he produces coffee. Specialty
Oh,
coffee. If you like specialty coffee, not the Starbucks kind of coffee.
exactly. The nice,
Clean, mold-free, mycotoxins-free coffee.
that
Yes.
is the yes. Oh, please bring me some if you're coming.
Yes. If you
Yes.
haven't done quitting your coffee, I would love to share some with you.
I'm not going to lie. Although I quit drinking coffee, I add coffee beans to a lot of things. So if
why are you gonna do that? I mean, like
I cheat. So I like to use it as an aroma in the house because I love coffee, right? And then if I make a smoothie, I may add coffee to it as well, right? If I make a smoothie and I make
bean inside. You literally
I have it. Yes, I blend it and I add it in. And I make, you can also make a lot of desserts with coffee as well.
Yeah.
So I have an ice cream maker and I have a dairy-free, I make a dairy-free coffee blend ice cream.
So next question for you is heartburn. And this is something that a lot of people are suffering, especially those people who are in deep stress. So do you know why heartburn gets so bad, especially during the time of 4 to 6 a.m. in the morning?
That's a great question. I wonder whether it has to do with cortisol coming up a little bit, right? A cortisol rise as we're waking up in the morning. And that, of course, will stimulate higher acid production in the stomach. And that will, I wonder whether, we know that the motility of the esophagus is related to the GABA pathways as well. And so I wonder if you're also super stressed, right? That can affect things as well if your GABA pathways are not, you're not in that relaxation mode. So I would say that is probably why. I think it's the cortisol. I think it's the GABA pathways, and maybe you feel it more as you're about to wake up. You may be having it throughout the night because there's something called silent reflux where people are refluxing. Like if you test them, they're refluxing, but they don't feel it until it gets really bad. So that's possible too.
And what is your point and what are the things that you can do to mitigate this problem? You mentioned about gut hypnosis just now.
Yeah, from a heartburn standpoint, from like reflux and heartburn, they say 40% of acid reflux and heartburn is related to nutrition and lifestyle and stress.
Mhm.
40% is huge, you know?
Yeah.
We're always looking for stuff, but that is huge. So I think for sure stress is a major cause of acid
Mhm.
reflux and heartburn. Very often we're like, no, it's not related to that. But we do know that stress can cause acid reflux and heartburn
Yeah.
and go all the way to causing gastric ulcers as well, right?
Mhm.
So really to reduce stress, really trying to reduce, balance out that parasympathetic sympathetic pathway in whatever shape or form you can do it, whatever shape or form. So breath work helps, intentional breath work helps, gut hypnosis, which is also, it's breath work, right? It's really
Mhm.
making sure that you're using the right muscles to breathe and you're opening up your lungs. You can do yoga if
Mhm.
you are into any kind of mindful relaxation technique, helpful. Acupuncture for some,
Mhm.
super
Yep. Yep.
reduce anxiety and stress, and it works really great for acid reflux too.
So for whoever out there, if you're interested to know more about breathwork or even gut hypnosis, follow Dr. V to find out more on her page. Okay. All right. So next one is my gut issue that's causing the bad breath?
That's a good one. Do you get
Mhm.
that question too sometimes, Dr. Shirley? Do you get that
Yes,
patient?
absolutely. Yeah, I even talk about how what are the things that you should look for whenever you're having bad breath. Yes,
Yeah,
and gut is definitely one part that we should never ignore.
yeah. That oral microbiome, so the bacteria in the mouth, is proving to be maybe more important than the gut, but we do really feel like it goes from mouth down into the gut, and some of them are resistant. So if the oral health is off,
Mhm.
that can infect, we know it can definitely cause gum disease.
Mhm.
It can infiltrate and into the buccal mucosa and get into the bloodstream, but it
Mhm.
can also be swallowed and bypass, especially if we have low stomach acid, bypass and then colonize in that small bowel, right? And so bad breath, I think absolutely could be oral microbiome issues. It could be dysbiosis of the gut as well,
Yeah.
causing bad breath, right? Because that gas that is produced by methanogenic,
Yeah.
bacteria or archaea, and also by whatever type of bacteria is releasing methane, hydrogen sulfide, which must smell
Mhm.
like rotten eggs, and
Yeah.
hydrogen, and that must smell bad. So yes, absolutely. And
Yes.
also something that's, the microbiome is so exciting. These bacteria also metabolize food and can even result in byproduct like alcohol, right? It
Yeah.
can even result in other byproducts, and that
Yes.
can be released too. So lots of gases, lots of smells coming out from the gut for sure.
Okay. All right. So next one is about anxiety and GERD. What is your stance on this? So can really the GERD is causing the anxiety, or the other way around, that the anxiety is bringing up the GERD?
Yeah. So that's a really good question. I feel like GERD is like IBS. It's
Mm-hmm.
one of those diagnoses where conventional GI feels like we got it down. It's GERD, take a PPI. But I
Mm-hmm.
feel like GERD can be caused by so many different causes. It's almost just like a symptom of something else going on. And
Mm-hmm.
one of it is anxiety, and the way this affects the gut brain axis and affects the neurotransmitters and affects the vagal nerve. And now, how is that sphincter relaxing, or is it a motility issue? Because, we talk about melatonin. Most of the melatonin is also produced in
Yeah.
the gut, and we can talk about the impact of anxiety on melatonin, the impact of the immune system. So yes, I do believe it could be both, but anxiety causing GERD makes a lot of sense, because GERD in itself, it's almost like saying diarrhea or something else. What is the
Yeah.
root cause of that GERD? And when we figure out what the root cause of the GERD is, then we can really start treating holistically and see the anxiety go away as well. Yeah.
Mhm. All right. Okay.
Mhm.
Very lovely input from you. And the next is, can poor gut affecting health? Sorry. Can poor gut affecting your hormones?
Oh yeah. Poor gut motility, dysbiosis can definitely affect your hormones. Like Motility is an issue, right? So if you're constipated, you're not going to be clearing all your estrogen metabolites breakdown. So that's going to accumulate in your system. You're going to likely just have hyper estrogen dominance. So more bloated, more moody, more irritable. And another thing too is that a lot of these bacteria in our gut are partially responsible for that, what we call the what do we call it? Estrobolus.
Yeah.
And so really involved in the pathways of making these hormone substrates, right? And hormone breakdown products. So definitely a poor gut dysbiosis, we know now, can affect so many things, right? And hormones is definitely one. Definitely.
So apart from female hormone, do you think that they also affect some other stuff, like maybe that's not particularly hormone, but neurotransmitters?
Absolutely. I do think they affect neurotransmitters. I also feel they accept insulin, which is another hormone. So we see definitely dysbiosis and insulin resistance as well. They can affect the thyroid as well. So I think on multiple levels, a lot of the protein precursors are affected by dysbiosis because they're involved in that pathway. Yeah.
I always believe that when you have a poor gut, nutrition is going to be missing. And when you're missing the nutrition, there's no way you can generate all the hormones that you need, right?
You can't make you don't have the amino acids, you don't have the proteins to make them. Absolutely. Yeah.
All right. So last questions about colon cancer. And I think this is very important. We need to educate people out there. When exactly is the best time to do your screening, especially if your family history of colon cancer?
Family history of colon cancer, you just want to do it early, right? And in the past, I think we still say 10 years before that family member was diagnosed, if it was someone under 60, right? Today, we are screening the average person at age 45. So if you're 45 or over like me, you should have had a colonoscopy. You should have had some form of screening. It doesn't have to be a colonoscopy, but you should have had some form of screening. And if you had a family member who had colon cancer at age 50, then you definitely want to screen earlier, like age 40, so 10 years before their diagnosis, right? So that's something that's important to remember, 45 for everyone, but much earlier if there's risk factors and family history.
So it really depends on at what age your family member got the colon cancer, right?
Absolutely, yeah.
And next thing is about, let's say if they were to get screened, and you were mentioning about colonoscope to be done, right? What about any, there's new thing that's coming up. There's I think in the States it's called as a Galleria, or it's an early
the blood test, the Galleria blood test, that one is looking for gene mutations, I believe, if I'm not mistaken. We do a little bit of that on multiple different cancers. So it's looking to see, do you have the genes that may increase your risk of certain types of cancers? I think that test is actually really helpful if you have a strong family history of cancer and you may not have the full family history. Sometimes we just don't know our family history that well, or they don't want to share the information about their personal history, so it's hard. But if you have some incline or you have family members with multiple cancers, then I think the Gallery test there's a role for it. Now, I know we are in a world of a lot of data, and so some people are just getting it, right? Just let me just do it because I can afford to do it. It's hard for us to really figure out how to counsel these patients who have no family history, nothing, who may pop up with 1 or 2 mutations, maybe heterozygous mutations, and give them guidance in terms of how to screen. So I think it has its place, but it's not for everybody. I think everyone should start with the basic preventative screenings based on age or based on your risk factors. But Gallery is certainly a tool that's helpful for some people, very much,
Then what do you think about tumor marker? Because a lot of people are so afraid to go on a scope with all this possible sedation and whatnot, and then they want to just rely on tumor marker to determine if they will have a chance of getting a colon
Or
cancer.
something. Yeah. So we shied away from tumor markers because we knew they were not always super sensitive or specific. We have some patients with full-blown colon cancer who CEA, which is one of the tumor markers for colon cancer, is totally normal. But now we are looking at biomarkers, right? Different types of biomarkers that can help us. And so now you have a blood test. There's a company that was FDA approved, at least here in the States, called Shield under Garden, that does a blood test that has a pretty decent sensitivity and specificity in the mid to high 80s and in the 90s. So that's not bad. So you just get your blood. Then there's a stool test, and the company we use here is called Cologuard, and you just poop in a box and it checks for genetic precursor markers as well as blood. That's also good. You can do that every 3 years. There's the FI-FIT test, which is looking for the globulin, like the actual protein of blood, which is more sensitive. That's just stool test. You can do that every year. And then there's the colonoscopy. So you have so many options: blood, stool, and then the colonoscopy. But I will say this, though, Shirley, because we were talking about high-risk patients. If you have a family history of colon cancer, you personally have Crohn's or ulcerative colitis, you have been exposed to radiation therapy, like pelvic radiation therapy, you are high risk and you should get a colonoscopy. And the other two modalities are for people who are sort of average risk to low risk.
I see. So same goes to like stool for occult blood. What do you think in the conventional time where we just use the stool for occult blood? How accurate is that as compared to the other modalities?
Not so accurate, which is why we use the FIT test, FIT, which is looking for the protein actually in blood, which is more specific. It definitely is. I think the FIT test is a good test. It's more accurate.
All right. So let's say the person is going for a colonoscope and it turns out to be negative, everything is good. How often would you recommend them to continue doing this kind of screening?
So the guidelines are there. The American Gastro Association has clear guidelines. If the person has family history of colon cancer or lots of polyps, they have like a brother who has like lots and lots of polyps every year, then the recommendation is every 5 years, right? And I'm a little bit more cautious about but if there's no family history, nothing at all, I usually say 8 to 10. They usually say 10, but I say 8 to 10 simply because we're seeing so much colon cancer and I'm nervous to wait for so long, right? But it is 8 to 10. And other people that we don't think about that we should be screening more often are our patients with diabetes. They are much more higher risk of colon cancer because insulin resistance and diabetes is directly correlated with increased number of polyps. And the polyps turn into cancer. So your diabetic patients, you definitely want to be more aggressive with screening as well. And I would lean towards screening, every 5 years, depending on the patient. And then personal history of other types of cancer, like breast cancer. If there's a BRCA1 gene, so it depends on if you have other cancers too.